Dear colleagues, dear students, we continue the psychiatry education from the University of Page. This is the 5th year, first semester, and today's topic is dissociative disorders, trauma and stressor-related disorders. As you know, in the previous weeks, I had a lecture on anxiety disorder and another lecture on somatoform or somatic symptom disorder, somatoform disorders, and today there is a lecture on dissociative disorders and these trauma-related disorders. And these three topics, the anxiety, the somatoform, and this one, previously were called as neurosis. I'm sure that you are familiar with this term, the neurosis, which is different from psychosis. Classically, psychiatric disorders were divided into two big groups, the neurotic group, when the patient has an intact reality testing, normal reality testing. There are no psychotic symptoms, but the patient shows some complaints and suffers from some complaints and shows some symptoms as anxiety or somatic-like symptoms, or these symptoms which we will describe today. And this was called the neurotic group, the neurosis group. And there was another group, there is the other group, the psychotic group, when the patient shows symptoms which leads to a disturbed reality testing as hallucinations or delusions. So from the DSM-3, this neurosis concept was excluded from the psychiatric classification, so you do not find this, but you can find it in all the textbooks, and everyday language uses the term that somebody is neurotic. So this is why I wanted to introduce this term. Now in psychiatry we speak about the phenomenology of the symptoms as anxiety, as somatoform, and as dissociative ones, but you have to know that previously this was a big group of neuroses. So let's see what dissociation is about. Dissociation is a periodic separation of memory, consciousness, sensory and motor functions. Normally, these four are associated, they are related to each other. In certain trauma-related periods, dissociation as an ego defense appears and protects the individual from the stressful life events and internal tensions. So dissociation is a kind of defense against the unbearable trauma, unbearable serious stressor, and this is what we speak about in this case. Some rare phenomenon also appears, and this is what in the slide I write, not all cases are abnormal. For example, highway hypnosis is a so-called normal dissociation phenomenon, when dissociation appears due to monotony. The patient, the individual drives a car on the highway and just staring at the road, and it leads to a kind of altered state of consciousness, which is not related to a trauma, but it's just a rare example of the non-trauma related dissociation, which hypnosis also is. But in most of the cases, dissociation appears as a serious trauma-related ego defense. There is no sharp distinction between normal and dissociated states. For example, disasters, floods, wars can lead to mild dissociative phenomenon in everybody. In these cases, dissociative phenomenon can appear as depersonalization, derealization. Depersonalization means that the patient feels that he had been changed. He's not the same. He has an inner feeling of being changed. Derealization, that the patient feels that the environment was changed somehow. And amnesia, the patient forgets some aspects of the past. So this is also an interesting phenomenon, that trauma and disaster-related dissociative symptoms can appear. In the DSM-5 and in the ICD-10, these are the dissociative disorders, these are very important, we have to know clinically. The dissociative identity disorder, which was previously called multiple personality disorder, that the patient has different personalities which do not know about each other. And the classical example, as we will see, is the Dr. Jekyll and Mr. Hyde book by Stevenson. And I will describe this later. So this is a rare but existing phenomenon. Dissociative amnesia, when the patient tends to forget what was traumatic for him or her. Dissociative amnesia with dissociative figure, when the patient travels due to a trauma and travels to somewhere and forgets why he traveled, forgets where he started to travel. So somebody has a memory that he had been at Page in the middle of Thursday and wakes up in Budapest at Saturday morning and doesn't have any memory trace how he reached Budapest. But during the travel, he talked to others in the train. He talked to the receptionist at the hotel and so on. But there will be an amnesia for this. And this so-called dissociative traveling or dissociative figure is a very interesting issue. Very important to exclude organic background, because in temporal lobe epilepsy this kind of traveling can appear. It was much later, much previously it was called poryomania. So this can happen in epilepsy or in some kind of alcohol intoxications or drug intoxications. This kind of cloudiness of the sensorium can appear, which is very similar to dissociation. So we have to exclude these other causative factors. Depersonalization, demoralization disorder, when the leading symptom is the feeling of being changed. And there are some other specified dissociative disorders as trance or brainwashing or recruitment by sects or cults. And there are two dissociative disorders which appear only in the ICD-10 and not in the DSM-5. These are dissociative stupor, when the patient has an extreme decrease of psychomotor tempo. The patient is mutistic, doesn't speak, but can speak, but not able, not willing to speak. And negativism, the patient doesn't follow any instructions. This is dissociative stupor. And Ganser syndrome, which, as we will see, is a special type of cloudiness of sensorium which appears in prisons or in army related to a serious trauma. And this is the book by Robert Louis Stevenson, where he, in a novel, wrote about a doctor, Dr. Jekyll, who turned into a murderer during the night, and this other person was Mr. Hyde. Dr. Jekyll didn't know about that he is Mr. Hyde during the nights. Mr. Hyde didn't know that during the day he is Dr. Jekyll. So these two separated individuals are the literary example of dissociative identity disorder. This is to mention. There are other books, as The Fifth Sally, for example, which also introduces this illness. Childhood traumatization is common in dissociative identity disorder. More females, so the sex ratio is 5:1 to 9:1 in these cases. In the American psychiatric population, the prevalence is 2 to 5%. So among all American psychiatric patients, this is the prevalence rate. Half of the patients have more than 2 personalities, also interesting. And the course is many times chronic and recovery is rare. So it's not a simple disease, it's very frequent, very chronically progressing. What we have to know, and this is a mistake which some people think about, that this is what schizophrenia is about. Schizophrenia is a quite different illness. In schizophrenia, the patient doesn't have these alternating personalities as in multiply personality disorder or in the recent term dissociative identity disorder. Schizophrenia, the splitting of the personality, the schisis of the personality in schizophrenia is quite different. In schizophrenia, the patient has 2 words, the psychotic word and the non-psychotic word, but these 2 words know about each other. The patient believes that he delusionally believes that he is an agent of the FBI, and parallelly he knows that he is a psychiatric patient in page, and these two words, the psychotic word and the non-psychotic word, coexist, and they have a communication, they know about each other. This is quite different if we compare this to dissociative identity disorder, when the personalities, the alternating personalities, do not know about each other. So dissociative identity disorder and schizophrenia has no common overlap. These are quite different. In dissociative amnesia, we have to know that this forgetting is not related to CNS diseases, not related to central nervous system diseases, or poisoning or exhaustion. In dissociative amnesia, the patient forgets the traumatic event. The patient has a serious stressor, the patient has a serious trauma and forgets it, and there is an inability to recall important autobiographical information, usually of a traumatic or stressful nature. So this is important. Freud had a book in the beginning of the 20th century which was called The Psychopathology of Everyday Life, when Sigmund Freud had dealt with this psychological forgetting phenomenon, and also focused on the trauma-related and unconscious-related forgetting. What we forget what we don't want to remember, said Freud in his early book. The phenomenology can be localized when, for a specific event, there is an amnesia. This is more common. And the phenomenology also can be generalized, so generalized amnesia, for the identity and the whole life history. And there is an American thriller film series with the main character of Matt Damon. The film titles The Born Identity. There are some parts of this film where this patient, this person who was an agent of the CIA, developed generalized amnesia related to a serious stressful life event and serious exhaustion and serious trauma, and he forgot who he was. And the whole film is about the searching for the memories, searching for the identity, and this is the Born Identity film, and Matt Damon was the main character, actor in this film. The next syndrome I would like to introduce is Ganser syndrome. In Ganser syndrome, typically the symptoms appear in prison or in army and seriously related to trauma. Serious trauma is the background. Patient or the person is raped by many individuals or seriously aggressively beaten, and all these traumatic events can lead to a certain type of disturbance of consciousness of the sensorium. The typical symptom that there are wrong answers to questions. For example, the patient asked what is the result of 2 to 2, and the patient will answer 5. And the patient is a university student. And this is not a simulation, this is not a conscious simulation, not a conscious imitation of a kind of dementia, but it's a kind of special dissociative phenomenon. Regressive infantile behavior can appear, hallucinations can appear, decreased state of consciousness can appear, and conversive symptoms can appear, and it's very important to mention that it's not malingering, it's not simulation. Often disappears spontaneously, but sometimes therapy is needed. For example, antipsychotic medication is needed. The etiology of dissociative disorders, 2 approaches can be mentioned here. The first is that it generally and typically it's a reaction to trauma. So this one approach. The second approach, that dissociation is a specific personality characteristic. Some personalities tend to dissociate more than others. And what we see in the case of narcissistic and borderline personality disorder, the dissociative is a very well and very frequently used ego defense, a very frequently used psychological phenomenon, which also in this case is sometimes connected to trauma, but without trauma, this is a kind of characteristic working mode. Important, the differential diagnosis. You see that it's very important to exclude neurological illnesses as epilepsy, or in the case of dissociative amnesia, you always have to exclude cerebrovascular disorders as TGA, transient global amnesia, or the amnesic syndrome, the Korsakoff syndrome, or head trauma. These all can a little bit mimic this group of illnesses, and we have to exclude this before we reach the diagnosis of a dissociative disorder. And also psychiatric problems should be excluded, like acute psychosis, schizophrenia, bipolar affective disorder, and malingering. Also important to exclude, because it can happen that somebody in a serious traumatic situation somehow consciously try to escape from the situation by malingering, by simulation, but in this group of illnesses this is not the case. Okay, the treatment is psychotherapy, supportive, empathic atmosphere, exploration of the trauma sometimes, and the reintegration of the dissociative part of the personality. What is dissociated in the illness should be associated again. What the patient couldn't tolerate should be tolerated again. The trauma, the stress should be integrated back to the personality, which sometimes, as a psychotherapeutic work, is very stressful for the patient and very difficult for the patient, but this is the psychotherapeutic goal. Pharmacotherapy can be antidepressants or anxiolytics. The other topic of today's lecture are the trauma and stressor-related disorders. And what we have to know here that 60 to 70% of the population suffer trauma during life, but symptoms rarely appear. So trauma is in a big percentage of the population is a frequent event and with no psychiatric consequences. And what we know from the Vietnam veterans studies of the Vietnam War period, that among the American soldiers after the Vietnam War, about 30% showed trauma-related disorders as PTSD, as post-traumatic stress disorder, but only 30%. And the other 70% who experienced the same traumatic events of bombing and napalm and deaths of small children and a serious attack by Vietnam soldiers and so on. So they didn't show the symptoms of PTSD, but only 30% showed the symptoms of post-traumatic stress disorder. In the DSM-5, the recent classification system, in the recent psychiatric classification book, these are the trauma and stressor-related disorders. 2 is related to childhood. 1 is reactive attachment disorder, when the mothering is not good and leads to a kind of attachment problems, connection to the mother, attachment to the mother, engagement between the mother and the child is disturbed, and this is what we see in reactive attachment disorder. Disinhibited social engagement disorder, when there is a frequent and uncritical interaction with unfamiliar adults. So the normal fear, the normal anxiety from unfamiliar persons do not exist here. So it's a kind of overwhelmed sociality from the child. It's also an attachment issue. The third illness is PTSD, and the duration of the serious trauma-related symptoms are more than 1 month. The other illness is acute stress disorder, where the duration of the symptomatology is from 3 days to 1 month. The symptomatology is nearly the same. And the last stress-related, trauma-related disorder is adjustment disorder, where the duration is maximum 6 months. But in the case of adjustment disorder, the stressor is mild, and the reaction is not as serious as in PTSD and acute stress disorder. So these are the stress and trauma-related disorders in the DSM-5. which are the symptoms of PTSD? Which are the symptoms of post-traumatic stress disorder? And 4 clusters can be differentiated here. The first are intrusive experiences as flashback and nightmare. Flashback means that the patient, in a pseudo-hallucinatory form, experiences again and again the stressful life event, the rape, the serious being bitten phenomenon, and so on. Or nightmare can appear when during the night the patient wakes up in a terror because of a terrible dream which we call nightmare. The second is the avoidance of the traumatic memories. The patient cannot face with them. The patient is not willing to deal with the traumatic experience. The third symptom cluster are cognitive and mood symptoms as guilt and shame. And the last one, the fourth one, is increased reactivity, which means many times irritability or self-harm. So these are the 4 important aspects of PTSD phenomenon. And you can see in this slide the different issues which I just summarized. The therapy of trauma and stress-related disorders are crisis intervention in teams, supportive and empathic atmosphere. Psychodynamic and cognitive therapy can be used to explore the trauma, to deal with the trauma. And sometimes pharmacotherapy can be introduced as selective serotonin reuptake inhibitors or mirtazapine. Benzodiazepines are frequently given, although it worsens the effect of psychotherapy. So in the recent approach that serious traumatic event-related life events, the use of benzodiazepines should be avoided. So we should let the personality to somehow cope with the trauma and not reduce the tension too early, because it's against the psychotherapeutic working through. And with this, I finished for today. I wanted to summarize very shortly the dissociative disorders and the trauma and stress-related disorders. And don't forget that the anxiety, the somatoform, and this dissociative and trauma-related group are what previously for a century or for more than a century was called neurosis. We don't use this concept anymore, but the phenomenology and the psychological understanding of this group of illnesses are very important. And with this, I would like to finish for today. Thank you.